Hello, my name is Carissa Wentland, and today I will be discussing recent literature regarding pediatric deep neck space abscesses. I am a pediatric otolaryngologist at Children's Hospital of Michigan. I have nothing to disclose. These are my references and the studies that I will be discussing today. Overall, I want to discuss the etiology and the most common reported pathogens in deep neck space abscesses. I will review the different deep neck spaces and different symptoms that will present within the different deep neck space infections. I will discuss different options for medical management and when surgery should be considered as opposed to conservative treatment with medical management. And then I will also go over the complications of deep neck space abscesses. Overall, deep neck space abscesses are very common, affecting 4.6 out of 100,000 children. These are mostly the younger kids under age 6. The etiology differs between young children and older children, teenagers, and adults. In the younger children, this is often due to either pharyngeal infections, necrotic lymph nodes, especially in the retropharyngeal space, because the younger kids have retropharyngeal lymph nodes, whereas these regress by the time the children are about age 5 or older, and you don't often see these in adults unless there's a history of foreign body or trauma. It can also be hematogenous spread or congenital cysts. Certainly, one should be suspicious for congenital cysts if there are recurrent deep neck space abscesses. Adults also have the pharyngeal etiologies, but you also would want to suspect odontogenic origins, and then again, for retropharyngeal abscesses, suspect foreign body or trauma. In order to fully understand the deep neck spaces, it's important to have a good understanding of the fascial planes because the fascial planes make up the deep neck spaces. And different layers of fascia go to different levels of the body, which means the deep neck spaces between those layers of fascia will then go to different spaces as well. And that's why certain spaces can present with different complications. So you have the superficial and the deep cervical fascia. The superficial fascia is outside of muscles such as the platysma and the muscles of facial expression. The deep cervical fascia is divided into 3 layers. There's the superficial or investing layer. There's the middle layer, which is further broken down into the visceral or pretracheal layer, and then the buccopharyngeal layer. And then there is the deep layer, which is broken down into the alar and the prevertebral layer. The retropharyngeal space is between the alar layer and the buccopharyngeal layer. And as you can see here, it's divided by a midline raphe. So oftentimes early in presentation, retropharyngeal abscesses will be unilateral because, again, there's a division between the different sides with the midline raphe. This goes down to T2. Behind that, between the alar layer and the prevertebral layer is the danger space. And it's called the danger space because this level extends down to the diaphragm, which can cause complications such as mediastinitis. And then finally, the prevertebral layer sits between the prevertebral fascia. In terms of what causes these deep neck space infections, this is a study out of Spain that looked at 330 cases of paratonsillar and deep neck space infections. This was throughout pretty much all ages, and they found that by far and away the most common etiology in their population was pharyngotonsillar infections. It's pretty astronomical, actually, that only 3% were due to dental origin in adults. In terms of pathogens, these are often polymicrobial just because there are so many organisms in the oral cavity. Staph is actually a pretty common organism as well, especially MRSA, and that's because the people that we actually get cultures of are the ones that have been resistant to medical management, which is why we drain them. So oftentimes we will see MRSA once we actually have cultures available. We all know that the group A strep species are very common in the throat, as are anaerobes being common in the oral cavity. Hemophilus is common just because that's one of the big three of the head and neck, and certainly in some of these necrotic nodes, they are due to infections that may have been due to sinusitis or problems like that then travel to the nodes, and then tuberculosis. And we need to be suspicious for atypical mycobacteria, especially when there's a neck abscess that has that violaceous hue over it. This is a study out of Taiwan that compared several recent studies looking at the common pathogens that they found for deep neck space infections. You can see here a lot of Staph aureus, both methicillin sensitive and methicillin resistant. And then again, the strep species are also very common. But the most common were either the staph or the strep in these studies. This is again that study out of Spain, and as you recall, most of these were paratonsillar abscesses from paratonsillar or pharyngeal infections, very low rate from other deep neck spaces. So the most common pathogens in this group were the strep species. In terms of patient presentation, most of these patients will present with a sore throat. And by the time they see us, they've often been treated by their PCP or primary care with antibiotics. Other symptoms really depend on the specific site that's involved. In terms of lab work, it's useful to have a CBC with DIF, electrolytes, coagulation studies if you're considering surgical intervention. If the patient looks toxic or if you're concerned for bacteremia, blood cultures can be important. And then if you do end up getting an aspirate, getting cultures is important to guide appropriate antibiotic treatment. In cases where the patient is immunocompromised or when there's clinical suspicion, it's important to get fungal and acid-fast cultures in addition to the aerobic and anaerobic cultures. In terms of imaging, there can be screening done with a lateral neck x-ray, and they're not always going to look beautiful like this in terms of having an air fluid level where you can clearly see an abscess. But what you're looking for is thickening of the prevertebral space. Normal levels would be in a young child less than 5 millimeters, or in other children 7 millimeters at C2. At C6, normal is 14 millimeters for kids and 22 millimeters in adults. And as you can see too, with these abscesses or the thickening of the prevertebral soft tissue, you lose that lordosis of the cervical spine. These are not as good as CT scans, and a lot of it is just because it can be technician dependent. And imagine young kids, it's very hard to get them to sit still, and the probability of getting this perfect lateral view isn't that great. Now, when looking at if the fluid collection is drainable or not, CT or ultrasound would be better at telling you that. When combined with clinical exam, meaning if the abscess is fluctuant, CT has been shown to have an 89% accuracy in determining if there is a drainable fluid collection present. Ultrasound, again, can be operator dependent, and oftentimes we do use ultrasound, especially when we're monitoring these people with medical treatment and monitoring their response to medical treatment. We can get repeat ultrasounds to see if a drainable fluid collection is developing. Although MRI gives great images, it's often not the best because it takes longer to obtain the images, and also a lot of children require sedation to have an MRI. And certainly one of the main concerns with deep neck space abscesses is airway compromise, and it may not be the best idea to have someone in an MRI for an extended period of time when airway compromise is an issue. Now to discuss the different deep neck spaces. So we're all familiar with paratonsillar abscesses, and these are something that we see more so in the older children and young adults. The average age is 25, with 65% of the patients being between age 20 and 40. Signs and symptoms include sore throat, dysphagia, fever, trismus and unilateral otalgia, and often when these symptoms are present, that's when there has been more extension into the lateral spaces, such as the parapharyngeal spaces, because inflammation is involving the muscles of mastication, such as the medial pterygoid muscle. Also, voice changes and malodorous breath can be common. The diagnosis is usually clinical, but sometimes CTs are available when a workup has been done before the patient gets to us. And we should counsel patients that these can be recurrent in 16% of adults and about 7% of children. And that's because a potential space develops between the superior constrictor muscle and the tonsil. And on that note, paratonsillar abscesses aren't technically a deep neck space because they're not technically within the fascial planes that we discussed, but certainly worth mentioning because a lot of other deep neck space abscesses result from spread from different areas. Now there's debate as to whether needle aspiration compares to incision and drainage. And this is a Cochrane review out of 2016 that looked at 11 studies, including 674 participants. It should be noticed that the risk of bias was either high or unclear in all of the studies, meaning it was uncertain why one technique was chosen over the other, and uncertain really if patients were more amenable to one technique versus the other. It really was not clear. The primary outcome in all but one of the studies was recurrence. They did find that the recurrence rate is higher in the needle aspiration group compared with the incision and drainage group, but the studies did not consistently measure other outcomes, such as adverse effects of intervention, time to resumption of normal diet, complication of the disease process, and symptom scores. In fact, adverse events were only reported by 3 of these studies. In terms of pain, 2 studies found that the pain of the procedure itself was lower in the needle aspiration group, and that should be noted that the other studies didn't even look at that. And then 1 study found similar pain between both groups 5 days out. And so this is really looking at how patients recovered from the disease process 5 days out, and that was found to be equal in that 1 study. Now this is a more recent study out of 2019 that compared needle aspiration to incision and drainage. It was a retrospective review of older patients aged older than 15 years, and they looked at 182 patients. These patients were all inpatient. Most of the time that was because they could not tolerate oral therapy or oral intake at all. They did find that the median length of stay was 2 days in the formal incision and drainage group versus 3 days in the aspiration group. So 1 day less in the IND group, which was significant. In terms of repeat procedure, 46.3% of the needle aspiration group required repeat procedure versus 10% in the IND group, which seems rather high. And then patients who ultimately needed intervention under anesthesia, there were 14% in the aspiration group compared to 4% in the incision and drainage group. There were no difference in complications, and they do acknowledge their limitations that the patients were not randomized, and the interventions were based on provider treatment preference or comfort level. So this study does hint that in the population that does need to be inpatient, so perhaps these patients may have more severe disease, that again, incision and drainage may be more definitive than needle aspiration. Moving on to intratonsillar abscesses. These are something that have been more recognized by providers. The abscess is within the tonsil itself rather than between the superior constrictor and the tonsil. Oftentimes there are multiple foci of fluid or areas of necrosis within the tonsil. The study out of Michigan found that when looking at tonsillar abscesses, 9% of these were actually intratonsillar. When comparing intratonsillar to paratonsillar abscesses, they found that intratonsillar abscesses presented with less trismus and otalgia, which makes sense because they're more medial. So like we talked about earlier, the trismus can be due to inflammation of the muscles of mastication. So since this is more medial, those may not be affected as much. And the same thing goes with otalgia. And then since again, the abscess is limited to the tonsil itself and perhaps not going as deep into the throat, dysphagia was found to be lower as well. They cited a study out of 2013 that looked at the common presenting signs and symptoms of intratonsillar abscesses, where 100% of people had sore throat, 90% had fever, and 81% had odynophagia. In the study out of Michigan, they found that patients with intratonsillar abscesses were less likely to experience acute progression from their initial symptoms, and less drainage attempts were performed. And this could be because there are those multiple foci of fluid collections, so there's really not that nice definitive plane you can get into and drain the abscesses. We found that overall, intratonsillar abscesses have less of a recurrence rate than paratonsillar abscesses, and overall they concluded that with these, consider medical management, because a lot of them do get better with medical management alone. Certainly in my experience, I have had a handful that I've needed to drain, and when you do drain them, oftentimes needle aspiration can be beneficial, but certainly it depends on the patient and the presentation. Moving on to parapharyngeal abscesses, these involve the space that is from the skull base to the hyoid and present with fever, neck pain, trismus, decreased neck range of motion, and sometimes too, especially in the pre-styloid ones, there can be the medialized tonsil. In terms of etiology, pre-styloid are often from extension from other deep neck spaces, such as a paratonsillar abscesses, and then the post-styloid compartment in children can be due to necrotic lymph nodes. Again, a true abscess may be more difficult to diagnose because it's hard to clinically feel the fluctuance sometimes, and being further away from the muscles of mastication, there may be less trismus, and sometimes even the patients have less pain and swelling with the post-styloid compartment. Moving on to the retropharyngeal space. Again, this is the space between the buccopharyngeal layer of the middle layer of the deep cervical fascia and the alar layer of the deep cervical fascia. Again, it is fused in the midline, so oftentimes these abscesses will initially present unilaterally, and this space extends from the skull base down to T2. Now, the retropharyngeal space in young children has lymph nodes on either side, and as I said earlier, these lymph nodes regress with age. The lymph nodes receive drainage from the nose, sinus, and pharynx, so certainly a lot of the upper respiratory infections can result in lymph nodes receiving drainage in this area that can ultimately enlarge and necrose. Signs and symptoms. With the retropharyngeal, you will have more of the neck pain, decreased neck range of motion, especially extension of the neck. Sometimes there can be neck swelling, but it may be hard to appreciate laterally, as again, these are more so in the midline or in the back of the throat as compared to a parapharyngeal abscess where you'd more commonly see neck swelling on the outside. These patients will commonly have fever, irritability, dysphagia, and drooling because it can compress on the esophagus. And certainly with any deep neck space abscess, you want to be suspicious for any breathing difficulty or any airway compromise. And certainly that should be ruled out and managed as soon as you see the patient. If you're lucky enough to get a good exam, which is very difficult in the young patient, you may see a unilateral bulge in the back of the throat. And sometimes, too, these may be higher actually in the nasopharynx, so that may be difficult to see as well. Here's an example of a lateral neck x-ray in a patient that had a retropharyngeal abscess. It was a 4-year-old who presented with 5 days of odonophagia, 2 days of fever, decreased oral intake, and torticollis with the head tilted inferiorly and neck turned to the left. The patient had a white blood cell count of 25, positive strep throat culture, and loss of expected cervical spinal lordosis on the lateral neck x-ray. And you can also see the thickening of the prevertebral space. Here you can see the trachea is somewhat deviated to the right. Here is the CT on that same patient, and again, it can be very useful because you can see this rim-enhancing fluid collection on the left side. Here in front of the vertebrae, you can see the hypodensity, and you can see that there is some normal tissue in the prevertebral area, which is suspicious for the retropharyngeal space. And then again in the coronal view, you see this rim-enhancing abscess. This patient ultimately underwent transoral drainage and was found to have group A strep positive cultures. Now, the danger space is that space between the alar layer and the prevertebral layer of the deep cervical fascia. And again, it extends from the skull base to the diaphragm, which is why when abscesses spread to this space, there can be complications such as mediastinitis. Initial presentation is nearly identical to retropharyngeal abscess, and most commonly these are caused from extension from adjacent neck spaces. Behind the retropharyngeal space is the prevertebral space, which extends from the clivus to the coccyx. Patients with prevertebral space abscesses will often have back, shoulder, or neck pain made worse by swallowing. They may also have dysphagia or dyspnea, and causes can be a Pott's abscess, which is an extrapulmonary manifestation of tuberculosis, trauma, osteomyelitis, extension from the retropharyngeal or danger space. Good antibiotics for deep neck space abscesses would be in a non-allergic patient, a penicillin in combination with a beta-lactamase inhibitor, such as Augmentin. Otherwise, you would choose a beta-lactamase resistant antibiotic in combination with a drug that offers anaerobic coverage. There is also debates on whether the use of steroids is beneficial. We know steroid use can help with pain and decrease edema, but steroids can also have immunosuppressant effects. Also, it may mask or make the patient look better than they actually are. And sometimes when we're medically managing patients in the hospital and we're looking for resolution of symptoms, we follow things such as the white blood cell count, which could be falsely elevated by steroids, and also symptoms such as neck range of motion, swallowing, and these may be falsely improved due to the use of steroids. So we wouldn't want to send the patient home prematurely based on the use of steroids. Now, there's not a lot of literature out on the use of steroids in pediatric deep neck space infections, but this is a study that just came out in 2020 from the University of Tennessee, looking at patients who had deep neck space abscesses and were treated with steroids versus the ones that were not treated with steroids, and they looked to see how many patients required surgical intervention. It was a retrospective chart review of 153 children. All of them received IV antibiotics, and most of them had dual therapy. And then a little over a third of them received dexamethasone at 1 milligram per kilogram, up to 10 milligrams every 8 hours for up to 48 hours, depending on patient improvement. So when you look at this first table, in terms of the children that received steroids versus the ones that did not receive steroids, the only things that were different were older children were the ones receiving steroids, and younger children did not commonly get the steroids. And then again, weight and height were significantly different, but it makes sense because older children are going to be taller and they're going to weigh more. Now, the severity of the abscess, meaning fever, white blood cell count, and even the size of the abscess, there was really no statistical significance between patients who received steroids and who did not receive steroids. And as you can see, these abscesses, the average size was pretty big. Now, in terms of the age of presentation between the different neck spaces, again, the peritonsillar space is typically in the older children, whereas the ones from necrotic nodes, such as lateral neck or retropharyngeal, are in the younger children. In terms of dexamethasone use by subsite, the highest group to receive steroids was the group with the peritonsillar abscesses. The lowest group was the one with the lateral neck masses. About a third of the retropharyngeal cases received steroids, and then a little less than 20% of the peripharyngeal spaces received steroids. In terms of patients who required surgical drainage, the highest group was the lateral neck. Next was the retropharyngeal space, followed by the peritonsillar space, and then the peripharyngeal space. Cultured organisms, the most common was MRSA, like we talked about earlier. Oftentimes this is because these are patients who failed medical management, so it's not uncommon to see the resistant organisms. And then the next two common organisms were methicillin-sensitive staph and strep pyogenes. This table compares the patients who received steroids compared with the ones who did not receive steroids, and ultimately the number that needed to have surgical drainage. And as you can see, overall, between all the groups, there was statistical significance, meaning the patients that received steroids were less likely to need drainage than the patients who did not receive steroids. However, when you break it down by individual subsite, the only subsite that was significant was the paratonsillar space. If you look at the retropharyngeal space, actually there was no difference between the patients who needed steroid or who received steroids versus the ones who did not receive steroids when it looked at the patients who needed drainage. And really, it's hard to even create any meaningful conclusions from the lateral neck because there were only 3 patients who received steroids, and out of those, only 1 needed drainage. Now, hospital length of stay, there was no significance between the patients who needed steroids versus not, or who received steroids versus ones who did not. There was no difference in the length of stay. Now, in considering observation with medical management versus surgical treatment, this is one of the larger studies that came out in 2013 that looked at 178 children with retropharyngeal or parapharyngeal abscesses. They found that the main risks for failure of medical therapy were age, less than 51 months, ICU admission, which makes sense because the more serious abscesses would likely need ICU admission and drainage, and then size greater than 2.2 centimeters on CT. Another study looked at 93 children aged 16 and under with retropharyngeal or parapharyngeal abscesses. All of these received broad-spectrum IV antibiotics and IV dexamethasone. They found that age, white blood cell count, and CRP were not predictive of the need for drainage, so age is a little different than the previous study, but then they did find that diameter greater than 2.5 centimeters was a good predictor for the need for surgery. There was no significant difference in the length of stay between the groups, and in those managed surgically, outcome and length of stay did not depend on the yield of pus. So that's good to know because oftentimes we bring these patients to surgery and we don't get any purulence expressed, or sometimes we just get a little bit of murky fluid that comes out of the abscess cavity. But really, in surgery, opening things up and dividing the fascial planes to release compartment pressure can be therapeutic as well. So when is intervention immediately necessary? Certainly if there's airway compromise, sepsis, complications, or no improvement after 48 hours of IV antibiotics, then intervention should be favored. In terms of complications, there's about a 2.2% risk of life-threatening complications. One of the main ones we worry about is airway obstruction, which has a little less than a 1% chance. Lemierre's syndrome is thrombophlebitis of the internal jugular vein, which would present as tenderness over the SCM or angle of the mandible, possibly septic emboli. This can be diagnosed with high-resolution ultrasound, CT with contrast, MRA or MRV. Treatment would be with culture-directed antibiotics, anticoagulation if there's thrombus progression or septic emboli, and extremely rarely surgical ligation or resection of the internal jugular vein. Mediastinitis has been reported to be in about 1.2% of these, with a mortality rate as high as 40%. Carotid aneurysms are extremely rare, but would present with a pulsatile neck mass, pharyngeal bleeding, and management would involve help from our vascular surgery or interventional radiology colleagues, and it could include ligation, stenting, or occlusion. Necrotizing fasciitis is subcutaneous tissue necrosis where the skin goes from pale to mottled to purple to gangrenous. There can be rapid progression and systemic toxicity. Treatment involves securing the airway, aggressive antibiotics, surgical debridement, and then ICU monitoring and support. And then finally, cavernous sinus thrombosis due to the valvulus veins in the face. However, this is more so for facial abscesses as the deep neck space abscesses. Certainly, with airway compromise, the majority can be successfully managed with intubation, but rarely there is the need for emergent tracheostomy. This should be anticipated in all cases. This is a study that just looks at, out of 510 children under 5, 51 of them had complications, with the most common being airway obstruction, needing intubation or trach. Multiple surgical interventions and sepsis were lower. This shows risk factors for complications. So they found that the younger kids and children with multiple abscesses or retropharyngeal abscesses had more complications than children with abscesses of other sites. So in general, since deep neck spaces are something we commonly see, I hope this was a good review for everybody. First and foremost, airway compromise should be ruled out and treated if present. Paratonsillar abscess can be diagnosed clinically, and in terms of needle aspiration versus incision and drainage does seem to be a little more successful based on current literature. Certainly, CT is useful for surgical planning in the other deep neck spaces. And then close observation with antibiotics and admission is definitely appropriate for a lot of patients as long as there are no complications or airway compromise. And certainly some of the predictors of need for surgical drainage are larger size abscesses, such as the ones over 2.2 or 2.5 centimeters. But other than that, if the patient's doing okay, it is reasonable to offer 48 hours of IV antibiotic treatment. And that's the end of this talk. I hope everyone has a great virtual conference, and if there are any questions, feel free to email me. Take care.